speaker today is Caroline Johnson, and Caroline is a general practitioner. She's a senior lecturer at the University of Melbourne, or she might be after her email this morning. And she's a very active clinical practice, and her research has always had a strong focus on primary mental health care, and she represents the College of General Practitioners on the Equally Well Alliance. Thank you, Caroline.
Thank you. Thanks very much. There are two Carolines here, so I just opened the wrong Caroline. What a cool thing that is. Alrighty. Okay. Thanks everyone for being with me and hanging in for the fourth speaker. It's great to be here. So I'm here to talk about a project that I was very lucky to be involved in with the group from RMIT, some Equally Well people, so acknowledging all those people. And I got invited to this gig because they needed a clinician who could look at some of the clinical data, and so I really take no responsibility for all the other clever stuff. Chris is here and he may want to chip in. But particularly in the team, I want to acknowledge Lucy, because she certainly was the one who put this abstract in, and she's moved on to another role, which is why I got the gig to be here today to talk about this evaluation project we did. So this project is situated in the northwest Melbourne PHN, so I'm from Melbourne. I'm not actually in that region of Melbourne, but this is the area that we're working in. So for those of you who are interstate, you get an idea of where it is. And we do know that in this population, in this catchment, people who access public mental health services have a life expectancy of 52 years, so that's 30 years lower. So it's probably at one of the worst ends of where we could be in the equally space when we're talking about mortality. And basically the PHN funded two different programs, NEMI and CoHealth, to invite people who experience severe and persistent mental illness and who were being or could be managed in primary care to get some help to manage their chronic conditions and to offer them extra supports. And it's really important to emphasise the funding had to be within existing services, not designing a whole new service. And right away as a GP, I already said, well, actually we want to prevent people getting chronic conditions, so maybe we're not targeting exactly the right group, but it's still an important consideration. You know, how early do you start? This was for people who already identified as having physical health problems. And this is just to give you an idea of the consumer journey. This is the NEMI consumer journey. The CoHealth one was slightly different in the way that the peer workers were involved in the work. But like all good PHNs, just to give you an idea, they did have a patient journey where people came into the service, were sorted, and then offered this suite of things, you know, in the kind of screening, case coordination, and of course using, Vicky, the health prompt that NEMI developed. And we can talk a little bit about that as we go through. And then offering them and trying to connect them up to services that existed in the community. And the evaluation was really about, well, you know, what actually happened? You know, what was people's experience of it, the who, what, how, the program logic? Did it actually play out as intended? And did it actually, you know, help people to meet the needs that they had for their physical health, and particularly help them, empower them to manage those issues themselves? And then my big interest in being there as a GP was it integrated with, you know, everybody else who's doing this work and trying to help this problem. And the really interesting thing, which is a real carrot for me to get involved when Chris asked me, was to actually be doing the work with people of lived experience, actually being involved in the program, and that was a very rewarding part of the program for me. So how did we do it? Well, it was a mixture of methods, but mainly involved in interviewing a lot of people. My role in it, along with the nurse in the program, was to review all the files, to actually look at the health information and say, well, can we tell from these that the people got the care that we think they should be getting? But there was also lots of interviews with family members, with carers, with the staff in the programs, and some focus groups as well. And then a very thorough look at all the documentation in the program, so very holistic, and an attempt to get some quantitative data, which of course in PH land is often challenging. And if you can access the report now online, and it was an interesting way of synthesising all this data using what's called a consumer profile approach. So those of us in traditional research methods might be familiar with the term case study research, but people aren't cases, they're humans. But the kind of idea of taking bits of information from the data and creating a profile that gives people an idea of this is what the experience was like. So it's a really nice research method for capturing qualitative data in a meaningful way, in my view. And this is just to give you an idea of how much we're talking about. So quite a lot of people involved didn't quite reach the target of consumers we would have liked to have interviewed, but I guess with COVID in the way and all the disruption that came, it's fantastic that these people, the 27 who did share their experiences, did so. We managed to look at 26 files in quite in depth and interview a lot of other people. And the external stakeholders there, that includes, other people working in general practice, primary care, that kind of thing.
Just add to that, Caroline, that 27 was everybody who wanted to participate.
That's
so it wasn't as if we could have spoken to more.
That's right.
Asked everybody, it was only 27 and
Yeah, so it was quite a good attempt to get people to give people the opportunity, and well done, Chris, because it was probably quite a lot of work during a pandemic. Poor old Chris, who initially would have been actually on site and doing all these things face to face, really had to do this whole thing virtually, which just adds a whole extra level of complexity in terms of relationship building. So these are the physical health people that the people who entered the programs encountered, and I think the main message here is, we know that people die of heart disease and cancer, but the things that people were being recruited to the program is because they mainly had problems like chronic pain and respiratory disease. Not to say they didn't have cardiovascular disease, but it's a real reminder of how chronic pain services in the community are really under-resourced, and so these are the people who fall through the gap because they can't get the care elsewhere. The other thing is, when we looked at diagnoses, again, we often think of the group with serious mental illness as people with psychotic illness, bipolar disorder, but in fact these people all had more likely to have problems with mood disorders or anxiety disorders. So again, technically you could argue maybe not meeting the people who have the biggest morbidity mortality gap, but clearly these are people who definitely need the service because they've got physical and mental health issues that coexist. So I'm going to talk a bit about my experience doing the file review, because that's why I was on the team. So we basically pulled together all the clinical practice guidelines that, nurses and GPs would be told, you must follow these because this tells you what you should do. And we looked not just at guidelines about screening like the RACGP Red Book, but also nursing standards, and a few documents about how professionals should collaborate together and what that should look like they should actually talk to each other and communicate. Do they actually do that? But the really cool thing was having a lived experience researcher in the team who talked about looking at these files through the lens of intentional peer support principles, and really saying, well, did these people actually get these things of connection, mutuality? Was their worldview explored? And were services designed to help them move towards their goals, not just what the guidelines said? So this was the richness of a multidisciplinary approach, is just having those conversations about, well, which of the things do you prioritise, what the guideline says or the experience of the person, and how do you reconcile those, which is really what people delivering programs and the people receiving programs are experiencing all around the country every day of the week. And that's what we learned, that balancing all those different competing demands was really quite challenging. If people come to the service saying, I've got chronic pain and I need help with, finances or looking after my cat, it's not that helpful to say, well, you also actually need a blood test and a cancer screening x-ray, and even if we get you to get that, how would we actually get you to the service or follow up that you had the service? So reading the case files, there's lots of evidence of people making suggestions, but not a lot of evidence of closing loops and following through. And that's one of the challenges with these programs, I guess. That's what we learned, and that led to really interesting discussions within the team about, well, which things should we be prioritising? Just to kind of sum up what we found after all those conversations is, first of all, consumers did like these programs. There were lots of very moving quotes about the fact that no one else had shown them the care and compassion that they got from these people who were helping them navigate the system. And here's an example of a quote like that. So there's no doubt we need this human connection in these kind of services when we're trying to do this work. The other thing is the stakeholders loved it, and I certainly got to speak to a few GPs involved in the program, and they basically thought it was awesome, game-changing in terms of connecting people to the services they need. This is a quote from a nurse who was involved. So it's certainly acceptable within the health community how it would be integrated. But the big problem we have is you've got to refer someone somewhere. If someone says, I need help with feeding my cat, or I need help with getting food, or I need help with getting to screening, lots and lots of stories of the suggestion being made, but the actual closing the loop not being possible. And here's a quote that represents that. And I have to say, my experience as someone who works in a practice of mixed, private and public practice, there's no doubt that if you don't have money to pay in Victoria, you don't get the same allied health services as someone who has the income and resources, no matter how much we'd like to aspire for an equitable system. And then there was quite a lot of there, and I won't speak in depth on this, but Chris might want to add later, there's quite a lot about the lack of clarity of the role of the peer worker in the programs in general, like people not even knowing that the person they interacted with was a peer worker. So here's a little quote that captures that kind of confusion of what on earth a peer worker actually is. And then there's the real lack of integration with public mental health services. So most of these patients were, recruited sort of in-house. So they were already going to NEMI for psychosocial support, or they were already going to co-health for GP services, and they were the ones who were pulled into this service. But the people who might be most likely to benefit probably weren't in this population. So again, when you create these extra systems within a service, because you don't want to build a new service, what happens is people who are already not getting the care they need within the service get an extra bit of service, and that's probably not the most efficient way of doing this. A small pilot program like this, it's hard to sort of say we had tangible outcomes where we can say this many people got their cancer diagnosed or their heart disease reduced. That wasn't the aim of the thing. It was just to sort of see, could it work? And certainly we do think there's evidence that there are changes in attitude to health and increased health literacy, and a little bit of evidence of better connections beyond the healthcare system and within the healthcare system. Probably some increased screening. So people who went to this program did get referred off and have things like mammograms and fecal occult blood tests and maybe some blood tests. What we can't say is when they got those things done, what actually happened to them in the longer term. That wasn't really part of the methodology here. In terms of limitations, unfortunately, COVID is we can blame COVID on a lot of the challenges we had. Certainly the service providers were unable to provide quantitative data in a timely manner, and I know in the PHN I work in, I know this is a perennial challenge for PHNs to actually deliver the services on a shoestring and collect the data that everybody needs to say it works is an ongoing challenge. And particularly, during a pandemic, staff turnover is high, but also we know in PHN land there's a lot of fixed term contracts, short contracts. That low job security and that staff turnover really makes it hard to make these changes really stick. And particularly this was in particular very small pilot, very small time frames in the middle of a pandemic. And I think those things kind of limit the transferability of what we learned, although we did learn some interesting things. So to finish up, these are the recommendations we'd like you to take away from our experience evaluating this project. First of all, with physical health screening, it really does need to be conducted thoroughly, and the health prompt's an example of that, but we couldn't tell whether these people had also had a health screen from their GP. My big bugbear was I couldn't tell anybody's family history, which is something that really bothers me. Like if I have a patient in my practice who says that both their mother and their father and two brothers died of a heart attack, that's really important information for me to use to help them get the screening they need, but none of that was really evident in this program. In terms of equity to access, the people who struggled the most with this program were culturally and linguistically diverse communities. We didn't have the evidence of people in public mental health services accessing it. So when these programs are designed, actually having some specific strategies to make sure that all these people and people of all genders can be involved is important. Care coordinators, well, we think it's good that care coordinators aren't one specific discipline. In this program, they were mainly nurses. I guess the message is that if you're going to do physical and mental health care, you need to have care coordinators who understand both those systems. More recommendations about peer workers and peer support, and basically one of the big problems that this program highlighted is you can't put people into a program when you don't really have a model for peer work that's working really well. So these peer workers really need that. Either they need to come into the program with a lot of experience themselves, or you need to make sure that they're properly supported and that they have a model that they can work with. And then you need to, once you've got that model, you need to then keep evaluating whether you're being true to that model rather than just putting people in a role and not supporting them, because if we do that, we'll never get anywhere with trying to build the peer workforce. Service integration, again, this kind of thing of who's responsible for what, and this is my big bugbear, the idea that GPs might be doing these tests, but the program isn't even talking to the GP, and nobody really knows where the buck stops, who's accountable for what. So we would argue that co-location does help that, but how do you achieve co-location at a population scale is something to reflect on. our recommendation is that these things are based in primary care or in the NGO world, not in the public mental health service. That doesn't mean people who are accessing public mental health services should be excluded, but more that there should be a way of making sure that there's that integration and making sure when we pilot these things that we get the size and the time frame right with staff who can stick through the whole program, because that would obviously also help us get more useful data. So really just saying this pilot was lots of learning to be gained. I think there's lots of benefits from continuing this, and we hope that the PHNs and service providers will continue to work on this and continue to get care coordination happening. So thank you very much.
Thank you, Caroline. Are there any questions for Caroline?
Oh, okay. Or for Chris. You can ask Chris a question too. Chris did the bulk of the work.
I think something really interesting that I would like to add is that because we did midterm review and we did a final report, and I got quite cross in the midterm review that there was no one coming in from the Public Mental Health Service. What's going on here? And as we investigated the pathways and experiences and data a bit more, there's not much care coordination you can do for those people. And this is the Public Mental Health Service where people were dying 30 years earlier. And one of the recommendations we made in the midterm review that Caroline ended up for was to move towards prevention. And people in the public mental health service system are past that. And so I think it's a really important question for this whole project, for the Equal project more broadly, that, who are we working with, what are we looking at? Because with this group of people who are not yet in the public mental health system, not yet in subject to coercive treatment in particular, there was heaps that could be done.
Yep.
Heaps that could be done. But when they got referrals into the public mental health service, it just wasn't the same. Capacity to make something new happen.
Yep.
So it's kind of a pressing, an important thing I think to reflect on who are we even talking about here, and some discussions about that. So,
Yep.
Yeah.
I agree.
Right.
I was wanting to ask that question about that, that kind of disconnect there where it wasn't so the program was accessible to the public.
Well, it was accessible. The people in NEMI who were already accessing NEMI services were told, oh, you've got a chronic physical health problem, we've got this extra thing that you can do. In the co-health, it was in a community health centre, but a lot of the GPs only heard about it kind of by accident because somebody was already in some kind of mental health something, and then the GP got told we can offer this extra help. So it was helpful, but that integration piece of it actually being visible within primary care, and then Chris is right. So for the people who are, experiencing their first experience of serious mental illness, they're the ones that they should be targeted right from the beginning. That you don't get any of the treatment for your mental health until we also make sure that you're getting the support right up front, so you don't become overweight and you don't get high blood pressure and you don't, et cetera, et cetera.
Yeah. So I was going to make that point because I think it's not that everyone who's seen by public mental health services has, super advanced disease or disability. The rates are high, of course, but the mental health services do see a lot of people, getting earlier, and perhaps it reflects the attitudes about who are we referring, who do we see needs support or prevention.
Yeah.
So it might be about shifting the perspective earlier to see the opportunity for prevention.
The program came about because the mental health service went cap in hand to the PHN and said, please fund us to provide the service. And they said, no, that's the state government's job. And so went ahead with it. Yes, there's demand, and then being like, okay, we'll tender. So it's come from them, but I do take the point about there is a variety of people that have been seen there, but in Victoria, or in any case, the law on the ground, the kind of just the way people describe it anyway, is that the acuities are much higher in most services than that's my experience too. In Victoria, it is a different kind of law. But one of the things we heard from the public mental health services was they're just too busy to refer to do anything.
Yep.
And so we're hoping that the next steps for this program, it won't be refunded as is, but with the reforms for the Royal Commission, it looks like something similar to this. And I know there's national stuff happening as well. Something similar to this in Victoria will be funded as part of the reforms out of the Royal Commission, and that'll be embedded into the services.
Yep.
Yeah.
I think it's probably where it needs to be. I mean, well, it needs to be in two places, but
Yeah, yeah.
Well,
I did. A lot of people told us they didn't want to work at Health and Health Services, and that's why they had to work with me.
yeah.
Yeah.
It's almost having different ports of access to it.
It's about that, but also not having specific criteria for people to be suitable to this service, removing all of those barriers, and people allowing people to refer themselves. So we did that with a program in New South Wales, and it was I think like out of the not a lot of people, but 80 people, like 60% of those people were self-referred and had self-identified with mental ill health and physical health. So we took out the whole thing of having to have a diagnosis of mental illness, and it really brought in people that we were looking for, not those people currently accessing services. So that was one way of doing it.
I'm just going to quickly thank everybody, but also just I think fantastic session. You know, sort of one example, two examples of where big data helps us know what's actually going on, where are the gaps, and two pilot programs using co-design, consumer participation, achieving, you know, not always the outcomes you want, but you can see where things can be improved, and really fascinating to see what, in terms of what your pilot will lead to once it's implemented, and we get the next stage of the journey, and then we can come back to Grant and say, have we made a difference? Is the data telling us that things are starting, the gap is starting to get smaller, which I think is what we all want to see from a lot of the work we're doing. As Russell said, we're halfway through the Wells fight, and 5 years in, so you know, hopefully we're going to start to see some of those changes. So thank you to everyone.